Good morning, everyone. Well, we're continuing our series of grand rounds. This morning and another time we'll cover hyperandrogenism. So hyperandrogenism in general covers the disease in which there is excess androgens in relation to estrogen. So at all time in life, the female ovary as well as the adrenal glands, they make both androgens as well as estrogens. If there is a preponderance of androgens in relation to estrogen, then you have some kind of imbalance. If you have a preponderance of estrogen in relation to androgen, that would be the normal. So our topic for this morning basically would be covering the polycystic ovaries, and then in next time we'll be covering congenital adrenal hyperplasias and intersexes. Between the two, basically from the shelf exam, as we were speaking earlier, these are the commonest topics that you will see, which would be polycystic ovarian syndrome, hyperandrogenism, adrenal hyperplasias, although not as common clinically, but definitely from an exam point they like that, and the amenorrhea. So we'll try in the next 3 or 4 weeks to cover those topics one by one in detail on a clinical level, basically how to evaluate and how to manage. Well, polycystic ovarian syndrome is a syndrome that has been characterized for many years, probably almost a century now. 2 guys in Chicago a long time ago, called Stein and Leventhal in 1935, were the first to coin the term. They had actually 7 patients in the initial series, and all 7 patients had the same thing. They're overweight, they're hirsute, they're amenorrheic. At those times, this was before hormones and before laparoscopy, so they couldn't really look into the ovaries, and they couldn't check the hormones. So the only thing they could do is to do a laparotomy. So they did laparotomies on them. They found their ovaries were big and cystic. So to be able to make a diagnosis, and sheerly from the point of being able to understand what's the problem, they took a wedge of that ovary and sutured the ovaries back together again. When they sent the wedge to pathology, it came back as follicular cyst and theca lutein cysts. But all those women started to menstruate spontaneously after years of amenorrhea, and then 2 of them got pregnant and the others got pregnant. So they said, well, this is very unusual. We just took those wedge biopsies to make out the diagnosis, and hence the treatment became obvious in the diagnosis itself, that all those women ovulated again and then menstruated and then ovulated and conceived. So a couple of years later, they published again in what was the American Journal. Then it's a bigger series, about 100 women, that they did the same. They were getting all those referrals. And since then, things have developed, as we will discuss this morning. But basically, clinically, there are 2 groups of patients. There is the overweight patients with the excess insulin, or what we call insulin resistance, as I will describe in detail today. And this is not everybody in polycystic ovaries, so I don't want you to coin your mental image that every polycystic patient is an obese, hirsute, and so on, because many of them are slim. So those patients too could be polycystic ovaries. As a matter of fact, most of our very difficult patients from a stimulation point, most of our higher responders are the slim patients. But their profile is very different. So in opposition to those group of women who have insulin resistance, and many of them, basically are pre-diabetic but are not diabetic, but have normal other female hormones, those women have high LH, basically also high testosterone, but normal insulin. Not only normal insulin, but normal insulin, normal glucose, and normal insulin sensitivity. So these are the 2 groups of women that we will see, and you have to treat them differently. You cannot all put them into one pot altogether as well. If you look clinically at those patients, every 100 patients that come to the office, say, and do not have a periods or have irregular periods, and you check them, 80% of them will probably be within a range of polycystic ovarian syndrome. About 5% will have the problem in the ovaries, and we coined that premature ovarian failure. And another 5% of the problems will be in the hypothalamus, and those are hypothalamic amenorrhea, mainly the ballet dancers, the excessive, the athletes who are very conscientious about their image, their performance, and their weight. So these are only about 5% with hypothalamic problems, 5% with ovarian problems as premature ovarian failure, but the majority will be what we call polycystic ovarian syndrome. They may present with period problems, but they also could present with hair problems. Hair problems, one of 2 things, either acne or indeed abnormal distribution of hair. So hirsutism, as we will cover this morning, is not really at all excess hair. Like if you have excess hair on the forearms, that's not hirsutism. That could be, racial. I mean, certainly, among the Indian races and so forth, there is tremendous excess hair on the forearm. That's not hirsutism. Hirsutism is the presence of hair in a male distribution, as I'll show you in a couple of minutes. Amazing, even among immigrant populations, if you take, for example, the Indian population that immigrated to the United Kingdom, and there is certain pockets in London, for example, that there is tremendous Indian population there, the incidence of polycystic ovaries is even higher than their own country. So the same group of people have increased in the population, and similarly in the Middle East, in the Emirates and so on, there is a tremendous movement among the Indian subcontinent, and the incidence of polycystic ovaries, according to the gynecology societies there, is in the neighborhood of 80%, even among adolescents. So with this just mental image of the syndrome, I want to tell you how we derive the diagnosis, or how can you make the diagnosis. Unfortunately, clinically, if you review charts, you will find that the diagnosis is not as accurate as you would like it to be. The first people to actually attempt to make the diagnosis was the NIH in the United States. In 1990, they had a consensus conference. And in this consensus conference, they wanted to define what constitutes polycystic ovarian syndrome. So they said we have to make it applicable to everybody, because there is no point that the diagnosis becomes applicable to Johns Hopkins, whereas the rest of the clinicians and the gynecologists of the country cannot apply the criteria. So they said you have to have two things. One of them is period problems. So if those women do not have regular periods. The second is excess hair. So the combination of excess hair and period problems constitute the basic diagnosis of polycystic ovaries. Well, in that pot comes lots of things. Like what? Like, for example, if you have ovarian tumor. There are some ovarian tumors that produce excess estrogen or androgens, like granulosa cells, Leydig cells, all that stuff. These are excluded because these are pathologic diagnoses. Also, Cushing's syndrome. Also, many other diseases like that. So you have to exclude other etiologies, whether you need clinical exam or hormones or other imaging techniques for that. But the only diagnosis you are relying on is two words, basically women who do not ovulate, and we'll come into to that in a minute, and excess hair. So what is excess hair? Whatever the patient says, that's excess hair, or whatever you think. So that's as simple as that. That's the clinical diagnosis. So what about anovulation? Normal menstrual cycle, 3 weeks to 5 weeks. Anything that falls out of the 5 weeks equals anovulation. So again, you can do all the fancy tests you like to do and check this and that, but at the end of the day, it's a simple clinical diagnosis. So any woman who goes beyond 5 weeks, that is called anovulation, and her cycle becomes an oligo-ovulatory cycle. So this was the initial diagnosis. It stayed with us. They joke about it. It's a non-consensus conference rather than a consensus conference, because most of the people attending there did not agree upon that diagnosis. It took years to come to more defined techniques. One major difference between the US and the UK, where many of the developments in the diagnosis of polycystic ovaries happen, is in ultrasound. So in European medicine, ultrasound is the cornerstone. I mean, you have to have an ultrasound that's showing an ovaries that have a certain pattern. If you have that ultrasound, they called it polycystic ovaries. If you have the ultrasound and a few other hormones that are deranged, and I will talk about them, that is polycystic ovarian disease. And if you have the ultrasound, the periods, the clinical problems, is polycystic ovarian syndrome. So for 20 years, the clinicians in the UK called the thing, one of three things: either PCO, which is polycystic ovaries, PCOD, which is polycystic ovarian disease, or PCOS, which is polycystic ovarian syndrome. These are the three things that were called by the Europeans. In the US, ultrasound was never, at the time, although ultrasound is widely used, was never taken as part of the diagnosis of polycystic ovarian disease or polycystic ovarian syndrome. So the two groups met in Rotterdam, in the Netherlands. The ASRM, the American Society for Reproductive Medicine, and its European equivalent, the European Society for Human Reproduction and Biology, met and put three criteria. So you're very familiar with the first one now, that these are women who do not ovulate. Second one is women who have excess periods. Third is polycystics. So let's see which will win. They kept debating, and then they said, okay, if you have two of those three, then you are you have the criteria for polycystic ovarian syndrome. So, for example, if you do an ultrasound and it shows polycystic ovaries, and then you don't have periods every 3, 4, 5 months, then you are polycystic. Alternatively, if you have excess hair and no periods, that's also polycystic. So any two of those three would constitute polycystic ovarian syndrome. The meeting was in 2003. The two respective journals, so the Fertility and Sterility, which is journal for ASRM, and the Human Reproduction, which is journal for HV, published the same paper simultaneously, same month, in April of 2003, to say this is the criteria that we should go by. So when we try to like make a clinical diagnosis, we try to abide by these criteria. There is a third society in the US called the Androgen Excess Society, AES. It was headed at some time by Dr. Aziz, who was at Birmingham, currently in MCG. But they were very unhappy with that definition. So why were they unhappy? They were unhappy because the definition, in some circumstances, excludes excess hair. So they said polycystic ovarian syndrome, by definition, is a hyperandrogenic problem. So if you take hyperandrogenism in women who have polycystic ovaries by ultrasounds and anovulation and make the diagnosis, then by definition you have altered the main concept of the diagnosis. So they said, yes, you have to have three, two of the three, but one of those two have to be hyperandrogenism. The Androgen Excess Society is correct in their philosophy or in their concept about that. However, in reality, their impact nationally and internationally is limited. So already the ASRM and the ESHRI sets the world standard basically for the diagnosis, and this is now what is considered for the past 10 years as the main criteria for diagnosis of polycystic ovaries. So done with criteria, I want to cover three things clinically, and then three things in treatment. So it is a purely, review of all the clinical issues. The three things that I want to cover, or the 3 points that I want to cover clinically, is the relation between insulin resistance and polycystic ovarian syndrome. And then the second one is the excess hair problem. How does it manifest itself, which is hyperandrogenism. And then finally, the third thing is what are the different ultrasonographic and laparoscopic appearances. So this is for the diagnosis. As far as treatment, three things for treatment. You can treat them by changing lifestyle, you can treat them by fertility drugs, or you can treat them by sometimes small surgical procedures. So let me come back to the evaluation and say I'll cover again insulin resistance, hyperandrogenism, and ultrasound. So from an insulin resistance point, actually all the major developments happened in Boston about 30 years ago or 35 years ago. A group of investigators said there that the issue with polycystic ovarian syndrome is not only an ovarian issue. So gynecologists cannot take the credit for that. It's more than that. So what could it be? They said that those women are at risk of diabetes. Okay, well, most of them are not diabetic. As a matter of fact, very few are diabetic. The insulin resistance is the key. The more insulin resistance the patient is, the more likely she is to develop polycystic ovarian syndrome. And this is true, but there is more to it than that. They said further on, if you correlate the serum insulin levels with the androgen levels in obese patients, you'll find they correlate. In other words, every time a patient have higher fasting serum insulin, the higher her testosterone or other androgenic products as well. Not only that, if you take slim patients, you might find that they also have insulin resistance. And if those slim patients get heavier in weight, they will develop a worse degree of insulin resistance. So this was the initial criteria that they found in 1980 for women with polycystic ovarian syndrome. So what are the metabolic effects? To exaggerate it to you, there is two components. There is a component of genetic predisposition, and then there is a second component, which is insulin resistance. So the genetic the predisposition for those women is basically they inherited something wrong, and I'll come to that in 2 seconds. Tell you what did they inherit that is wrong. And then the second one is that with this inheritance, they are now predisposed to PCOS. If they indeed become heavier in weight, this situation will be exaggerated, and it's a multiple factor. In other words, if you take a patient that is born with polycystic ovarian syndrome, taking it from her mother or her dad, and she is polycystic, and then she becomes heavier, she would develop more insulin resistance as well. The insulin resistance is so crucial that if you want to contrast polycystic ovarian syndrome who ovulate versus who do not ovulate, you will find that the insulin resistance is a big problem. So what do I mean by that? What I mean that if you look at 100 patients in the society today that have polycystic ovarian syndrome, 80% of them will get pregnant on their own. They will never make it to the point that they come and see anyone for help. It is only the remaining 20% that have reached a point, either in their derangement of the LH and testosterone or in their insulin resistance, to a point where they will need assistance. Of those 20%, 10% will respond to simple measures like clomiphene citrate and these kind of drugs, which would cover. The remaining 10% are coined in literature clomiphene citrate resistant PCOS. So this is the 100%. 100 women, 80%. So, and similarly with many of the diseases we try to cover in the last few weeks, like fibroids, endometriosis, you see every patient that you're doing, every third patient you're doing a C-section has fibroids. So you say, how come fibroids cause infertility and all those C-sections are in women who have fibroids? Yeah, because again, about 70-80% escape, but another 10-20% suffer the consequences depending on the location or size of fibroid. Similarly with endometriosis. I mean, lots of patients with endometriosis conceive, but then at a certain point, they do not. And here the key is insulin resistance. So those women who have high fasting insulin are more likely to be anovulatory compared to PCOS who have normal fasting insulin as well. Is it subcutaneous fat or is it visceral fat? It is visceral fat. Visceral fat is the one that carries all the risk of it. I don't encourage either, but certainly visceral fat is more dangerous than subcutaneous fat in terms of all the metabolic issues that we will discover today. And we said that basically the obesity is a contributing factor, but it is not the only prerequisite. It's certainly, there is genetic factors. There are cutaneous markers. What do you mean by cutaneous markers? That the patient, when it comes in on clinical exam, there will be some markers that make you suspect that those women have insulin resistance or suspect that those women indeed have polycystic ovarian syndrome. One of them is acanthosis nigricans. So in white patients it will be black pigmentation, or in black patients it will be actually depigmentation or white markings at the back of the neck, as very clearly seen in this patient. Also seen in the axilla. If you look for the striae in the axilla, look at the side of the neck here. These are perfect criteria for suspecting PCOS, acanthosis nigricans, and insulin resistance as well. There are many things that get deranged in those patients. I mean, most of them are related to insulin resistance. Others are related to interleukins and plasminogen activator factors. And these are some of the reasons why many of those patients are predisposed to either inflammatory condition or even cardiac conditions that are well coined as metabolic syndrome as well. So we mentioned that those patients have inherited something wrong or something different. So what is different in the PCOS compared to the second patient beside her who does not have polycystic ovarian syndrome? Most women with diabetes have either no insulin or lack of insulin type 1 or have insulin resistance type 2. With those insulin resistance in the normal population, whether males or females, they either have an abnormality in the receptor or less number of the receptors. Whereas with PCOS, neither exist. So the receptor number for insulin is normal as well as the quality of the receptor. There is no fault as the receptor. It is the steps that happen after the insulin attaches to the receptor that is at fault. So what is the difference between the two groups of women? In normal women, the insulin attaches to its receptor. It results in a phosphorylation steps. It's a tyrosine phosphorylation steps in all of those patients. Whereas in polycystic ovarian syndrome, it's a serine phosphorylation. And this is the only difference between the two of them. So if you have a serine phosphorylation, basically one amino acid difference between the two, you have a change in the cascade of events from there that changes the interleukins, that changes the plasminogen activator inhibitors, and plasminogen activator inhibitors have lots of effects on the endometrium. We can cover that in another topic. And all those would result in some of the manifestations that you see, so that those women have endometrial hyperplasia and also occasionally develop to endometrial carcinomas. But this is the defect. That defect is compounded by the obesity. In other words, obesity makes insulin resistance for a variety of reasons. So it makes it basically difficult or more costly for the insulin to push the glucose molecule inside, say, the muscle cell. So normally the glucose comes in the blood, you have to transport it inside. That transportation is insulin facilitated, and this facilitation is decreased in obesity, but more so in women with polycystic ovarian syndrome because of the difference in phosphorus. That has been actually discovered about 15 or 18 years ago, that difference between the phosphorylation in women who have polycystic ovarian syndrome on this side versus women who do not. And it also results in, if you have excess free fatty acid, you encourage this kind of phosphorylation, and it is prevalent also in some other enzymatic problems that are associated as well. In the natural history, when you see today a woman who have polycystic ovarian syndrome and have diabetes, it didn't just suddenly appear. There is a number of years that happened before that. So this is the zero line of diagnosis. This is 15 years after diagnosis with the cardiac and renal complication. This is 15 years or before the diagnosis. So 15 years before the diagnosis, they were as good as her sisters are. But what happens is that at the beginning, a few things started to change. The fasting glucose is typically normal. So if you check the fasting glucose, no, it's definitely below 105. It's never normal. As a matter of fact, most of the time it's between 85 and 100 in those group of patients. If you check fasting insulin at the beginning, it starts as normal and that increases. So what do I mean by that increase? Normally, the ratio is 4.5 to 1. So if you have a glucose of 90 in the morning, usually you need about 20 units in the blood to make it 90. So the glucose to insulin is 4.5 to 1. If you still have a normal glucose, 95, and you have a higher insulin, this is insulin resistance. So actually one of our patients here, she's 13 years old, weighs 285 pounds, fifth grader, and basically tremendously overbuilt and have hyperandrogenic features. Her fasting glucose is 95, definitely not diabetic, but her fasting insulin is 105 instead of 15 or 10 or even better 5. So she's spending so much insulin to push the glucose inside, and hence she has all the criteria for insulin. When she's 13 or 15, she's as healthy as anyone. I mean, she's healthier than all of us. But give her 30, 40 years with time, just by age and obesity and all of that, she will develop all the features there. The other metabolic issues that are there are either glucotoxicity, lipotoxicity, and inflammatory. So all those things result in two things: in insulin resistance, as we talked about, resulting in obesity, dyslipidemia, and diabetes, but also in dysfunction of the endothelium. So the endothelial cell dysfunction is very important for those patients, and it is part of the etiology of the coronary artery disease in those patients as well. Finally, there is lots of impact on the liver and on the pregnancies on those patients, and the predisposition of their offspring to the same disease as well. So I think this covers the first part, which is the insulin resistance in those group of patients. Where does it come from? What is pathophysiology, and how did it develop? Amazingly, if you do an ultrasound at the beginning of the cycle, if they have a cycle, so if they have a cycle, we try to bring them on the second or third day. If you don't have a cycle, you bring them anytime and repeat it 2 weeks because you don't know when the ovulation happened. If you count the number of those follicles, and those are called antral follicles, so the antral follicle is the step before the egg is pumped out, they are big enough to be seen by ultrasound. So each of those is like 4 to 6 to 8 millimeters. If you count the number of those follicles, they correlate with the fasting insulin. So if you have a patient, as we'll talk, the clinical criteria is 12 follicles on each side. But if you have a patient with 40, 50 of them, so she has 90 follicles at the beginning of her cycles, and we have lots of those, then this correlates with her fasting insulin. Also, the thickness of the part in between the follicles known as the ovarian stroma, the thickness of that stroma correlates, and we'll come to that in 2 minutes. So this is, again, concludes the insulin resistance. What about hyperandrogenism? 2 words on hyperandrogenism. There is hirsutism, and then there is the acne part. The hirsutism is 2 parts, is really the appearance of hair in a male distribution. So it has nothing to do with the quantity of hair. But that appearance of hair in a male distribution means it's a midline. So you have a hair basically on the chest, on the sternum, between the breast, on the abdomen, between the umbilicus and the pubic bone. Ferryman and Galloway did a scoring system, actually 60 years ago. In 1952, published it in the JCEM, Journal of Clinical Endocrinology, and put a chart. They say, okay, if you look at the chin, at the lips, at the neck, at the chest, at the abdomen, and the pelvis, and give them a score from 1 to 4, you have those 9 sides, and you give them a total score. That scores represent the degree of hyperandrogenism. We actually copied that page from the paper 60 years ago and put it in the chart and just circled those. We circled them because we forget. I mean, you see a patient and then 6 months you see her, you think all you remember at the time is that she just had excess hair. And then the second is acne, and you're more familiar with that than anything. When you make a diagnosis, now we're getting more into the hormone part or the endocrine part. There are really 4 hormones that could be deranged. And I'll go through them this morning in more detail. There is testosterone, the famous female enemy and friend is testosterone. There is dihydroepiandrosterone sulfate, androstenedione, and 17-hydroxyprogesterone. So these are the 4 androgenic hormones that could be deranged. Very important, because with one evaluation, you could reach almost a diagnosis in this patient. What do I mean by one evaluation? Testosterone is produced in the ovary, in the adrenal, and also by peripheral conversion, outside the 2 of them. The higher the testosterone in general, the more you think that this problem is an ovarian problem. So if you have one test, if you're allowed a certain budget to spend on a patient, this would be the test. If you're working in a country, for example, I worked in the United Kingdom, and there is certain guidelines in terms of what do you do for the evaluation of this disease. It's called the NICE guideline, NICE, and actually I participated in formulation of some of those guidelines over the year. So, for example, in pregnancy, we used to check human placental lactogen and so forth at certain time. Well, really, there is no criteria today to suggest that these were useful, but part of the government budget was to allow you to do a certain number of ultrasounds and allow you to do a certain number of hormones. If you're allowed one, this is my story, do testosterone, if you just have one. If you have 2, then do testosterone and 17-hydroxyprogesterone. Why 17-hydroxyprogesterone? Because 17-hydroxyprogesterone is a hormone that is elevated in adrenal hyperplasias. So now you have covered almost all the clinical diagnoses that are common. You've covered adrenal hyperplasias, and you have covered polycystic ovarian syndrome. So adrenal hyperplasia, and we will cover it extensively, God willing, in another topic, is characterized by elevated 17-OHP. Typically, you should do it at the beginning of cycle and so on. Really, it doesn't matter. If it's above 1,000, you definitely have a diagnosis of adrenal hyperplasia. If it's below 300, it is normal. If it is between 300 and 1,000, you have to do further testing. Further testing like what? We give them the shot that is produced by the pituitary called the ACTH and check out how much 17-OHP they put out and how much was their basal 17-OHP. So if their 17-OHP at the beginning was below, say, 312, which is just almost normal, and it shoots to 2,000, then those women have late onset adrenal hyperplasia. The dihydroepiandrosterone sulfate is produced, the sulfate part, the S part, could only be done in the adrenal. The ovary does not have the enzymes that do the sulfate part. So the DHEAS is an adrenal problem. So elevation means an adrenal disease. Elevation above 700 micrograms per deciliter suggestive of adrenal tumors, possibly adrenal carcinoma. In clinical practice, we have never diagnosed one patient based on that. However, all the patients that were diagnosed for other reasons, like they came with a mass effect with blood pressure, and you check them, you find that. But it is never the first clue. So in clinical application, we do it, but we do it to make sure that the patient does not have a problem with her adrenal. And the fourth one is androstenedione, and androstenedione is elevated in polycystic ovaries. It's almost not elevated in anything else. So you have 4 hormones: testosterone, androstenedione, dihydroepiandrosterone sulfate, 17-hydroxyprogesterone. In adrenal hyperplasias, 17-hydroxyprogesterone is diagnosed if the level is above 1,000. In adrenal tumors or carcinomas, a DHEAS above 700 micrograms per deciliter would be diagnostic, and androstenedione above also 200 would be highly suggestive polycystic ovarian syndrome and testosterone. So what about testosterone? Testosterone is a male hormone that is produced in the ovary and in the adrenal gland. When it is manufactured, when it is made, it circulates in the blood. Most of it is circulating in the blood bound to another carrier protein. That protein for the majority of time is either albumin or sex hormone binding globulin. So the liver makes the sex hormone binding globulin that attaches the testosterone. So all that bound testosterone has no impact on the clinical features. So all the hirsutism, all these problems are only affected by free testosterone. So what normally is the free testosterone is 1%. So a normal female has 1% of the testosterone free. If that 1% becomes 2%, she becomes extremely hirsute. So the difference is not really in the testosterone level. Most of the patients with polycystic ovaries, with serious polycystic ovaries would have a testosterone level just around the upper level of normal. So the upper level is 20 to 70. So most of them are 60, 65, 70, 75, 80, which really, I mean, 75 is not different from 70, from 65. All these are criteria in our mind. But it is the free testosterone. If you have a 1% free testosterone, that is normal. If you have 2%, it's very abnormal. If you have 3%, she is on the male side. And basically this will be somebody that will be shaving 3-4 times a day. I mean, no question about that. That if you go to a 3% free testosterone, you will have literally to shave 2 or 3 times a day just to appear within the normal. You can also check the sex hormone binding globulin, very easy to measure and so forth. It will give you, the higher the sex hormone binding globulin means lots of your testosterone is bound and less of it is free. And some of the labs have the ability to give you what's known as the free androgen index, which is dividing the total testosterone by the sex hormone binding globulin and multiplied by 10, by 100. So again, let me re-emphasize that there are 4 hormones that could be measured. Certainly from a shelf exam, these are important because they want to take it to the next step. I mean, they don't want to say, well, hirsutism and so on, because if we say hirsutism, anybody passing by your office could make the same diagnosis. So really, you check 2 hormones in the outset. So most of the questions we will give you in the result. One of them is higher than the other, like 17-hydroxyprogesterone, and they try mostly in the exam to give you a clear-cut number, like 17 OHP of 2,000. So it's not like computer. I mean, they don't try to give you it's 288. But less than 300 is normal. More than 1,000 is abnormal. Between 300 and 1,000 warrants further testing. Further testing means ACTH stimulation test or cold cortisone stimulation test. We give ACTH, check a basal level, 30, 60, 90 minutes, and sometimes 120 minutes. For us, it is done by the pediatric endocrinologists at the shack in Old Providence, because basically all those patients have what is known as late onset adrenal hyperplasia. Late onset is the underlined word here. Why late onset? Because congenital adrenal hyperplasia in the US, 99.9% have been diagnosed by her pediatrician within the previous years up to that point. It would be extremely rare. Like, I mean, 20 years ago when we started here, there were just a handful of patients that missed through. Today, I think very few miss through because the pediatricians diagnose congenital adrenal hyperplasia very capably, depending on one of 2 features. If they have what we call intersexes, like they are in between a male and female as far as genitalia at birth, this is the commonest group of babies that get to the pediatrician and get diagnosed. The first diagnosis they need to do is 17-hydroxyprogesterone in those patients. Again, the HAS, they like it in exams very much because with one blood test you can diagnose adrenal carcinoma, basically 700 micrograms per deciliter. If it's above that, it's diagnostic, so it is one. Androstenedione is really more into like fertility exams and so on because it's more into polycystic ovarian syndrome. But these are your 4 hormones that you need to check on on some of the patients that would come in with hyperandrogenic disorders. Well, what about female hormones like pituitary, LH, FSH, anti-Mullerian, all that stuff? Typically, as the diagnosis of polycystic ovaries developed over the years, people used to think that those women have hypothalamic problems. So for years they said that the hypothalamic generator is a problem, and indeed they do have some abnormal responses of the hypothalamus and pituitary to other stimuli. In 1/3 of those patients, in 1/3 of those patients, they have elevation of the LH to FSH. So again, if you assume that the patient have a period every 2 to 3 months, and she comes today and she has a period, you try to schedule it within the next 2 to 3 days. If you schedule it, you check both LH and FSH. One of them does not mean anything. Because if you check the LH and FSH at the same time, normally the FSH and LH are how much? Give a guess. 4 to 8. So normally 4 to 8. So if you find her FSH is 4, but the LH is 12, very suggestive. If you find it 16, it's even more suggestive. If you find it 10, it's still highly suggestive. So elevation of the LH in relation to FSH. Why is it elevated? We really do not know. I mean, there are ideas, but we are not sure why do those women have LH to FSH. Is it diagnostic? In other words, should you rely on LH to FSH? No. This was the 1980s. We now do it to look at certain features. Women who do have high LH to FSH are more difficult to superovulate, to undergo fertility, high-end injections, and also more likely to lose the pregnancy. So women who have LH to FSH, high LH is a problem, but it's a different kind of a problem. It is not a metabolic problem. It is really an ovulation problem. It is possible, and as you know, all the eggs that are produced today have been in the factory for a good 2 to 3 months, similar to the sperms anyway. But they have been in the process there. The day that you saw them in antral follicle, what we call the starting point, those follicles have been there at least 2 months. So high LH to FSH. All those women have high anti-Mullerian hormone. Clear-cut picture here, the side, the burns in the head. Clear-cut pictures here. You have the chin. So the chin is here, and again, patient like that is shaving 2 to 3 times a day. If you look at the upper lip, definitely you see that a lot in postmenopausal patients. Not because they have low testosterone. They drop their testosterone and they drop their estrogen, but they drop their estrogen more. So if you take a 65, 75-year-old lady and you compare her to herself 30 years ago, the main difference is that she dropped the estrogens by 2/3 and she dropped the testosterone by 1/3. So all her hormones are low, but one of them is even lower than the other. Of course, you can see acne, and you can see acne with hair on the chin, as you see here, and this is very suggestive of polycystic ovary. I mentioned the distribution. So if you have hair in the middle of the chin, I mean, so somebody on the sternum should have 1 or 2, a handful of hairs. But if she has 20, 30 hairs, that is abnormal. Certainly, also the hair around the areola, I mean, a large number of hairs around the area is very suggestive of an abnormal distribution. So it is the abnormal distribution, not the quantity of hair that matters. So again, 4, 5, 6 hairs are fine. But if she has 25 hairs on each side and in the middle on the sternum as well. Normally, what we call the femoris petechiae is characterized by a triangular appearance. If it becomes an inverted pyramid appearance, that inverted pyramid appearance is very suggestive. So if you see, the majority of the patients would have shaved before coming. But if you see those patients and they have extensive hair in the midline, the only reason that would do that is excessive testosterone, free testosterone. All this is hirsutism, but it is not virilization. So virilization is a totally different story. It is not a degree above, it's a different story. So virilization is 3 things. Is a change in voice, is a change in the size of the clitoris, and hirsutism. The change in size of the clitoris, they could be born with it, which is what we'll talk about next time, in congenital adrenal hyperplasias, and that should be considered for surgical treatment. The change in voice is very unfortunate because it's irreversible. So there is no treatment for that. There is nothing that you can do or ENT can do to change your voice. Once the vocal cords, it's actually the layer under the surface of the vocal cord, it gets thickened, and it gets thickened so the voice becomes deep. So if she makes a phone call to somebody, say, oh my God, you're sick this morning, and she's not really sick. I mean, that deep voice, this is a very, very important point, and it's irreversible. You can't really do anything to it. For the clitoromegaly, it is surgically very easy to treat. What we do, we preserve the clitoris, the glands, and remove the shaft. And there is always a neurovascular bundle, a nerve and a vessel. Those nerve vessels are dorsal. So you keep the dorsal neurovascular bundle and reattach, and that is very, very easy to do. Historically, the people, undergone clitoridectomy, but that is totally unnecessary in those patients. So I covered hyperandrogenism and I covered the insulinism, hyperinsulinism. Now it is what about the ultrasound? So the ultrasound, I want to give you a few points, markers that are really, really essential today in diagnosis. These are not like details in ultrasound. The idea that the ovaries are big and so on. So a report of like what frankly radiology produced in the hospital is irrelevant to what, to the practice. Totally irrelevant. I mean, they look at like ovarian tumors, uterine tumor. No. I mean, when we look at the ovary, we have certain criteria that we are very specific about. This is a laparotomy, and show you clearly here that this is the uterus, and the ovaries are about twice or 3 times as much as the uterus. So a big ovary in relation to uterus in somebody with a normal size uterus who do not have disease is suggestive of polycystic ovarian syndrome. If you look at the ovaries, again, this is a laparotomy here, the uterus is here. The ovaries, look how big they are. If you open that over here, if you take the scalpel and open, this would be the appearance here. You have bundles or numbers of those small follicles that are sitting there. They look like cysts because they're follicles, but they are not cysts that warrants like surgical intervention in their own right. And then if you take one of those and magnify it here, this would be the appearance. So inside, there is a kind of cells called granulosa cells. On the outside, there's a different kind of cells called theca cells. And the egg sit here, takes with it a number of cells from the granulosa cells and change them, and they become the cumulus or ovules. So this part here is magnified there, showing you on this side the theca cells and on that side the granulosa cells. The granulosa cells function in like the world of reproductive endocrinology is a total world in its own right, because all what we do basically depends on this single kind of cells. What happens is that the pituitary produces FSH and LH, and you remember that. So the LH goes on the theca cells and produces testosterone, which is the male hormone. The testosterone makes the trip from the theca cells to the granulosa cells and goes inside. And another enzyme known as the aromatase enzyme takes the testosterone that was made by the theca cells in response to LH and converts it to estrogen. So the testosterone becomes estradiol, and the androstenedione becomes estriol. This is basically a summary of what is known as the two-cell theory discovered 40 years ago about how all this functions. So the granulosa cells is the most important cell. If you have preponderance of granulosa cells, known as granulosa cell tumor, you will have a tumor that produces estrogen as well. If you look at the uterus here and the ovaries are behind the uterus, again enlarged in those patients. And if the patient has completed her family and you've done an oophorectomy and you fix it, this is what shows up on the fixation of those ovaries here. And this is the appearance there. And also, if you look here, that would be the appearance in those. So again, multiple peripheral cysts that are present, each of them have to be less than 10 millimeters in diameter, and to make the criteria, you have to have a certain number. Again, laparotomy here, uterus, you see the ovaries, how they are pearly, and then you cut it, and you see the follicles are there, and then the cartoon in the lower corner shows you a large number of follicles there. If you do an ultrasound, and this is a transabdominal ultrasound, why transabdominal? Because the bladder is full, and you're seeing the ovary behind. If you fill the bladder, the ovary always show behind the bladder. And if you look here carefully, there is what has been coined as the pearl necklace appearance. Why pearl necklace? Because each of those small follicles situated here, the stroma is in the middle, and you have that ovary. That ovary is enlarged, as we will discuss in 2 minutes. This is a transvaginal ultrasound showing you that this particular patient had more than 12 follicles. So 12 follicles is one of the criteria that's now taken. This is not an assessment. This is actually criteria for diagnosis. So you have somebody who has 4 follicles, you can say that she has polycystic ovary, as long as you have looked for that. So we request that the number of follicles is estimated. I mean, if 14 from 16 doesn't hurt us, but 14 from 6 makes a difference in diagnosis, because also it will make an impact on what medications do you use, the dose of medications do you use, and so forth. The stroma is also increased, and the ovarian volume is increased. But all those follicles have to be less than 10 millimeters, each in mean diameter. So 12 follicles on each side, each less than 10 millimeters in mean diameter. Some areas have been in those meetings and other meetings a source of controversy. This is not like high-end research. This is very, very basic, everyday clinical information. You want to say the stroma echogeneity. You look at somebody and the stroma is very shiny. The stroma shiny is because of the excess lipid formation there. Also the volume of the stroma, the number of follicles, and certainly 3D ultrasound. 3D ultrasound is very useful because you can swipe it and then you take as many or as little cuts that you like to take. The ovarian volume correlates with ovarian function. So a volume larger than 10 milliliters correlates with polycystic ovarian syndrome. So I gave you now two criteria: ovarian volume, which is larger than 10 milliliters, or ultrasound showing you 12 or more follicles in each ovary. Each of them is less than 10 millimeter in diameter, between 2 and 9. So 10 cc or 10 milliliter is the magic number that has been used. It's not really magic, it's an estimate. It's trying to categorize people. Like if I say, for example, if you are 6 foot, you're rather on the tall side, but if you're 7 foot, you're definitely a very tall person. So this is the same here. The 10 milliliters is a bigger volume. So what is the normal volume? The normal volume would be like 4 to 6. Again here, a nice ultrasound. This is actually one of our patients, showing you here. This is actually from 2008, from January 2008. Multiple follicles, all peripherals, so pearl necklace appearance, more than 12 follicles on each side, and ovarian volume of more than 10 milliliter. The ovarian volume could be done either by calculation, and you can take 3 diameters and work out the volume, or could be done but that you go with ultrasound, then draw a line around it and get an estimate with the new software. You don't even have to multiply it in your head or in the machine. Again, abdominal ultrasound showing you peripheral follicular distribution. This is 3D ultrasound. So why 3D? Because you took one swipe and then it cuts it differently. So last time with the ultrasound, if you remember, we said there are 3 cuts. So if anybody still remembers, there is a coronal cut, there is a horizontal cut, and there is a sagittal cut. So there are 3 kinds of cuts with ultrasound, and anything on the uterus has to be done in the 3 cuts. Has to be done coronal, horizontal, and sagittal at the same time. Ultrasound here. We touched on the endometrium. Basically, the endometrium is a very, very dynamic organ, and definitely changes with many things. If you look at the end of the follicular phase of a normal ovulatory woman, this would be what it looks. It's called trilaminar endometrium. So she has white, black, white, black. The whites are the interface, like where the sound waves get reflected. We don't know why they are white, but this is the anterior endometrium, and this is the posterior endometrium, and the white here reflects the two between them. And we measure it from here to there. It doesn't really matter much whether you put your calipers outside and inside. This will be difference of less than 1 millimeter in the endometrium, but the endometrium is a very, very, very vital organ. If you start the first 2 weeks of the cycle, you have estrogen. The second 2 weeks, you have estrogen and progesterone. With the progesterone, it makes changes that prevents this endometrium from becoming excessively thickened, known as endometrial hyperplasia, which is this bundle here. I mean, you look in, is disorganized and is endometrial hyperplasia, and if you leave it long enough, it will change in endometrial carcinoma. It could take anywhere from 1 year to 12 years, and so forth, or even quicker if the patient has some genetic predisposition to development of endometrial carcinomas. So to summarize the investigations, you will have to do an androgen profile. What if you are working in Selma, Aranz, and so on, does not have facilities? You don't have to. I mean, you basically will have to go by clinical criteria. If the patient says, I am complaining of this, and she has no period, you really don't need to do any testing. But it has to be the periods are 5 weeks or more apart. So normally, the periods are 21 to 35. If they go beyond the 35, that's abnormal. It can't be correct. I mean, so regardless of the fancy test, this is anovulatory. In its own right is a diagnosis. So you don't need, and so on. Of course, if you do the testing, it is helpful. Why helpful? Because if the testosterone is 75, that is the common for polycystic ovary. But if it is 275, this suggests the possibility of an androgen-producing ovarian tumor. So on one hand, you don't need it to do clinical medicine, but on the other hand, you would benefit tremendously from doing it. Similarly, other hormones, like for example, the anti-Mullerian hormone. You might not want to do anti-Mullerian hormone. It doesn't affect anything in the patient's health. But if you're going to give her fertility drugs based on response, then you really want to have an idea, do I need to give her 1 or 2 or 3? 1 for cost, but more importantly, from side effects. And the side effects is not like rash or allergies, excessive response, which is a problem. Most of those patients have between 5 and 12% have hyperprolactinemia. Hyperprolactinemia means excess prolactin above 20. And some of them have hypothyroidism. Hypothyroidism means that the T4 is low, so the TS is elevated to compensate for the low T4. if the patient's T4 continues to dwindle down, continues to drop, she will produce more TRH with the thyrotrophin releasing hormone. The TRH stimulates the prolactin producing cells to produce prolactin. So this is the mechanism of hyperprolactinemia in women with polycystic ovarian syndrome. Finally, you have to assess glucose. The best assessment today, the simplest assessment because it's available because simply of obstetric, is a 2 or 3 hours glucose tolerance. So that's a simple assessment. And we check the insulin. The insulin is a must in those situations because many of those patients have normal glucose in the face of a rising insulin. But I mean, really 3 hours is the only way that you can check those. Of course, once you start to have those, you'll have to check their cholesterol and manage it or modulate it with diet. So, treatment, what do we do for treatment? Very briefly, it really depends what she came from because every patient has an objective or is at a different stage in her reproductive life. So, for example, patient A is coming in today and she has no periods, but she's 24 and is on a career and does not want to have babies now. So those patients do not need, for example, fertility treatment. I mean, you would need basically maintenance treatment. The simplest maintenance treatment for those is simply combined oral contraceptive, birth control. Very simple. It helps. I mean, it is not neutral. It is not in the neutral gear. It's helpful. Why does it helpful? For 10 reasons. Number one, the estrogen in itself, and the progesterone that is there, the progesterone would suppress their LH. So the suppression of LH would suppress their testosterone. So this is number one. Number two, the estrogen that is there increases the liver production of sex hormone binding globulin. The sex hormone binding globulin will bind their free testosterone and hence the free testosterone amount. So by the two, a combined mechanism for decrease their testosterone. If a patient is coming for hirsutism, the treatment for hirsutism or hyperandrogenism is anti-androgens. Birth control is not an anti-androgen. Is not, and I'll discuss with you anti-androgen in a minute. The patient is coming because of a weight problem, then you encourage weight loss. And as I'll show you in 2 minutes, if you lose as much as 5% of your weight, you can make 40% of those women ovulate again without anything else. So it's the simplest treatment for that, the least followed. And then finally, for fertility, there is a bunch of medications that we will cover with you today. So again, it depends what they came from. So some of them come because their periods are messed up. I mean, they have a period and then every 3 months, every 4 months, they are not predicting it. So combined oral contraception is very good. They have amenorrhea and they want to have period, or they have oligomenorrhea, then also combined oral contraceptive is good. If they're coming for excess hair, their only problem, they're happy, they want kids now, it's not in their plans. However, they have excess hair and indeed they are troubled by that, then the treatment is anti-androgens in addition to birth control. The part of the use of the birth control is for the reasons I mentioned to you. Also, it's protective because the anti-androgens are not good if you're going to have babies. You cannot take anti-androgens and have babies at the same time. If you take infertility, we'll talk about that. And then sometimes all you need to do is give them statins and metformins if there is a need for that. So of course statins will be indicated by the clinical criteria that are used. There is a big overlap between between those group of women and women who are seeing their internists for metabolic syndrome. And hence there is a higher usage of statins and higher uses of metformin in those patients. So I come back to the hirsutism, which is one of the 3 things we covered in the investigation. What about the treatment? So the treatment of hirsutism is anti-androgen. What does anti-androgen mean? It means a drug that either stops the production of testosterone or does not allow the testosterone that you have produced to work. So for example, if you have testosterone that is very active in its function, you can block its receptor. And this is partly how spironolactone is used. So spironolactone is a water pill. It's an aldosterone antagonist. It's a diuretic. But one of its side effects is it blocks its testosterone. So this is why it is used in this setting. In reality, to be used as an anti-androgen, it has to be high dose. So the amount of it that is used for blood pressure management or as an antidiuretic is not enough to be used as an anti-androgen. You almost use 200 or more to be used as an anti-androgen. So this is number 1. Number 2 is cyproterone acetate. So cyproterone acetate is what? It is a progestogen. A progestogen means it's a drug that is like progesterone. It is long-acting. Because it is long-acting, It is given in the first 2 weeks of the cycle because it stays for the whole month. So normally, women have estrogen in the first 2 weeks, estrogen and progesterone in the second 2 weeks. But here we're giving the progesterone in the first 2 weeks, which is not normal, because they cover the 4 weeks. The guy that did that is a German endocrinologist called Hammerstein. And because he reversed the norm, so it's called the reverse Hammerstein protocol. And this is the basis for making birth control worldwide. So the drug is, the birth control is called Diane, and a small amount, and Dianette, which is basically using a small amount, is the most common birth control pill used in Europe and the Middle East and all the way. It has never made it to the US, basically. So all those now are generic, so no company will invest into medication that will never be used, and they have never been also imported. But Diana or Dianette is the most common birth control used globally because of its very good anti-androgenic profile. The birth control, of course, has estrogen in addition to the cyproterone acetate. So the second drug is cyproterone acetate. The third drug is finasteride. Finasteride is a very popular drug in US, not for hirsutism, but for benign prostatic hypertrophy. It stops the 5-alpha reductase enzyme. So the alpha reductase have 5 isoenzymes. The drug is being based on the isoenzymes that are prevalent in the prostate, not in the hair follicles. However, it could be still useful because of the overlap. So what does 5-alpha reductase do? It converts testosterone to dihydrotestosterone, which is the more active form of testosterone. So use of an enzyme blocker does not permit the testosterone to be more active, and it's a good drug to be used. Its side effects are rather limited. Flutamide is another anti-androgen drug. It is approved in Canada. Its main problem is elevation of liver enzymes, and hence we very rarely consider flutamide. It would be you would prescribe it on your own assessment. It does not have an indication in the US for that. With all those androgens, there is ovarian suppression, and I mentioned to you birth control. And again, for exams and for every physiological reason, birth controls are estrogen and progesterone. The progesterone suppresses the LH, which suppresses the testosterone. The estrogen increases the sex hormone binding globulin, which binds the free testosterone, and hence you have lower free testosterone. You can also suppress the ovaries by giving them gonadotropin releasing hormone agonist. It suppresses the whole axis from the hypothalamus to the pituitary to the ovaries. Very effective, but expensive, and will cause osteoporosis in a short period of time. So be very cautious about that. Finally, dexamethasone or adrenal suppression is a very good drug if the source of the problem was adrenal. So in women whom we induce ovulation and they have also late onset adrenal hyperplasia, we give them dexamethasone 0.5 milligram per day in those patients or around that time. What about other measures? Of course, weight loss is the most effective measure, no question about that. If that fails, then you go for a few groups of drugs. Clomiphene citrate is the commonest. It's very cheap worldwide. It's available brand and generic. It's available everything. Insulin sensitizing agents like metformin and so on. There is 5 other insulin sensitizing agents. They have not made it to the wide audience because of their effect on liver enzymes. So metformin is the only one that survived as an agent. It compares poorly to clomiphene citrate, which is in itself is not does not have the highest success in the world, but certainly insulin sensitizers, metformin compares poorly to clomiphene citrate. For the whole 90s and 2000s, it was widely given for those patients until multiple prospective randomized trials looked at it, and they found that if you give clomid, it's better than you give metformin. If you give the two, it's possibly slightly better than clomid, but definitely if you give the two, it's way better than if you give insulin. But it has a place where in several indications, in patients who have insulin resistance, in patients who are diabetic, in patients who are hyper-responders, because by decreasing the insulin, you will decrease their testosterone. So you're not giving it because just because of the insulin, but because of testosterone. And finally, gonadotropins in a low dose is very effective medication for that. So weight loss, I mentioned to you, this was studied by Roy Homburg, who was in Israel and also in the Netherlands, and he showed that if you drop your weight by 5 to 10%, 55% of women will resume ovulation within 6 months of weight reduction. So in terms of like health policies, this is the most effective health policy that you can do, is really work on weight loss in this population. Clomiphene citrate remains in the US today to be the first line treatment, and like I said, if 100 women comes to your office today and they have polycystic, probably another 800 didn't make it because they got pregnant, but on those 100, half of them will respond to clomiphene citrate, and that's a good thing. And the other half will be coined as clomiphene citrate resistant polycystic ovarian syndrome. They're among the toughest of patients, not in terms of success, but you have to have balanced safety and success. And you can err on success and decrease safety, but at some point that could be very problematic. The dose is typically that is used is 50 milligrams a day, and it goes to 100, up to 250. I never use anything more than 150, so I never use 200 or 250. Basically, if somebody does not conceive on 150, you change group of drugs and so on. You have to monitor them, however, to know if they're ovulated or not, but giving it and finding at the end of 6 months that they did not get pregnant doesn't help the patient, because you don't know if she ovulated and failed to conceive, or if she ovulated and had other problems as well, versus if she does not ovulate at all. If you try the treatments and look at those women who conceive with clomiphene, the majority of them, like 3/4, would conceive within the first 3 months. So there is no point in continuing for 2-3 years on treatment. The majority will conceive within the first 3 months. And very rarely they conceive after 6 months. So certainly there is no clinical indication to conceive after 6 months. Again, in countries which write guidelines, in the US there is no guidelines, there is no way that, there is certain recommendations, but nobody tells you if you do not give 12 months, then you are at fault. That does not exist here, which actually is frankly the best way to practice. But in the United Kingdom, according to the NICE guidelines, they recommend definitely that you do not go beyond 12 months of treatment. That if you go beyond that, there is almost zero efficacy and just side effects. So side effects like what? The commonest is ovarian cyst, visual problems. 1.5% of those patients develop visual problems, and we have two patients that have been previously treated and had developed visual problems. Again, aromatase inhibitor is a new group of drugs that has been prevalent, has been available for 40 years. It's been the drugs that have been used for breast cancer treatment. They will completely replace tamoxifen as the adjuvant for breast cancer, but it's not tamoxifen that is used, although tamoxifen could be used, but it's not used. It's another drug called letrozole, and use the same dose, like 5 milligrams a day for 5 days, and it is a very efficacious drug at the low end. So again, if a patient if a couple has been trying a year or two and have not been lucky in that year or two, and they come to see you, and you follow them after 2 years for the next 5 years, and they come to your office and you're wonderful to them, and you're very, very nice, and you shake their hands every morning, the front desk are fantastic with them, they have a 1% per month for the next 5 years to conceive. 1% per month, which is extremely low. If I tell you have a 1% to finish med school today, I think many of you would be disappointed. But they have 1%. So if you give them all the Clomid that you have and give it to them and give them all those boxes and give it to them free, that doubles the pregnancy rate, which sounds astounding. But that's 1% has become 2%, maybe 3%. That's the end. That is really the end. Then if you give them fertility drugs, the injections and what we make a big thing, that's very efficacious. It's about 800%. Two more, which is what? 1% has become 8 to 12%. If you do insemination alone, without anything else, that gives them 8%. So that's actually more significant than all what I have said. If you combine the insemination with the gonadotropins, it doubles that pregnancy rate, so it gives them 12 to 18%. So you want to make it like most successful, but in reality, per cycle, it would be 12 to 18%. Of course, per patient, it is more because there is what is known as the cumulative pregnancy rate, like the odds of getting pregnant after several cycles. But each cycle is an independent unit. Take that, for example, in contrast to in vitro fertilization, and you look at the age of the woman. You take somebody who's 30 years old and has polycystic ovaries, she probably has a 70% chance, if not more, because she really doesn't have a problem. I mean, her problem is that she does not ovulate and so forth, but there is really no other problem. And I mean, many of those patients are like, recommended to have a hysterectomy and so on because they don't conceive, whereas really 80% of those women get pregnant on their own before they walk in, and the remaining 10%, if you do in vitro fertilization, you will actually end up with 70, 80%. Of course, for the young age group. I mean, you go, once you cross that 33, 34 years old, that's, you take that down by leaps and bounds. You cross the 40, you take it down to the single digits or teens. I mean, you're talking of a pregnancy rate of 5 to 25% at the best in those age group. Women, if you use gonadotropin, then definitely consider a low-dose gonadotropin and not a high-dose gonadotropin. Finally, if the patient cannot afford any medication and the health system the health system globally is a problem. I mean, there is no country that has found a solution for it. But if you can't and you happen to be doing a diagnostic procedure, consider doing ovarian drilling. It is a controversial issue. We have written extensively about it in the literature. I mean, to put it to you simply, the guys for example, in the UK, where the guidelines are spelled out, the person that writes the guidelines for those is the fellow that was after me. So in the fellowship long time ago. So he writes the guidelines for those, and he very much opposed to ovarian drilling. And I write supporting it. So he always writes at the conclusion that despite our tremendous enthusiasm about it, he thinks it still could carry hazards. The two hazards that are there is that you can cause adhesions. You keep buzzing those ovaries, so you can cause adhesions. So basically, you can convert an ovulatory problem to a tubal problem, and that's true. There is no dispute, but it depends also on techniques and the patient's dependence to adhesiolysis. The other problem for that is that you can, if you get carried away, if you're over enthusiastic, and I'll show you some of those ovaries another time. I mean, they're big ovaries, so you start drilling instead of 6 or 8, you start drilling 20, 25, you can cause ovarian atrophy, especially if you drill into the central part where the blood supply comes forth. So, of course, one should be cautious with that. And I think I thank you for your great attention this morning.